Professor Dr. Peter Hans Dietz, former professor in obstetrics and gynecology at the Sydney Medical School, University of Sydney, editor of Ultrasound in Obstetrics and Gynecology, and associate editor of the Australian and New Zealand Journal of Obstetrics and Gynecology. Welcome to Turkey. We are very delighted to have you among us, and it's so nice to meet you. My name is Amal, and I'm a resident in obstetrics and gynecology. There's a question I'm so curious about. Now, obstetrics and gynecology is a very wide field with many subspecialties, and you chose to focus on urogynecology. How did you take this decision when you were a resident?
Well, I came to obstetrics and gynecology via imaging. So I did imaging, I did ultrasound before I did ONG.
Oh.
So I started by scanning hearts and livers and gallbladders and kidneys. And at some stage, there was the opportunity to examine somebody with an 18-week pregnancy. So this got me hooked on imaging in ONG. And then I wanted to do, this was in Heidelberg, and I wanted to, during my studies, and I wanted to do an MD in this field. And the only MD project I could get involved translabial ultrasound. That was in 1986.
Wow.
And at the time, the idea was to use translabial ultrasound to measure cervical length in premature labor and to look for placenta previa. And that can be done. You can see a placenta previa with translabial ultrasound, and you can measure the cervix. It's just everybody does that with vaginal ultrasound now.
Yes.
And in 1986, that was not that big. There wasn't that much vaginal ultrasound, and people were afraid that they may do damage. Like in somebody with a placenta previa, people thought if we put a probe on the cervix, we may stir up bleeding. And then there was always the bladder, and there was always the urethra. And then at some stage, I'm not sure whether it was me or somebody else, we had the idea of looking at bladder function, at comparing findings with what we did at the time with urodynamics was called a lateral cyst urethrogram with X-ray.
Wow.
So an X-ray like so with a fluoroscopy machine. And this is how we started looking at bladders and the urethra, and it all went from there. It became clear that the utility, the clinical utility of that approach was much higher for urinary incontinence and for prolapse. And that was in 87, 88, 89.
That's really nice.
Long time ago.
Yes. In a recent article you published, you mentioned the pelvic floor injuries after normal delivery, and the main way to diagnose is by doing perineal ultrasound. When do you think, as a resident, I'm supposed to for sure do perineal ultrasound? When can I use it for definitive diagnosis? What advice would you give residents for based on this
say your sister has had a difficult delivery, a shoulder dystocia or an occipito-posterior baby, and you want to know whether she suffered any damage. Or a friend of yours, or maybe just a neighbor, or maybe a patient. You've just done a very difficult delivery, and you want to make sure you haven't done any damage, okay? Or a vacuum, or here is not much forceps, so that's good, no forceps.
Yeah, it's not used frequently.
Yeah, that's very good. But you want to know. And I would, you can scan somebody after 5 or 7 days, but it's messy. The pictures are not very clear. There's blood, there's hematoma, there's edema, there's suture material, there's detritus, there's gas, there's air. So, and it's sore. When you place the transducer, she'll be sore. So if you really want to know, do it just before you send her home, say on day 5 or so, but bring her back after maybe 8, 10, 12 weeks, up to 3 months. And then the picture is going to be a lot clearer.
Up to 3 months.
Yeah. Examine as well. Examine.
Yeah, for sure. Physical examination.
You can, of course, you can feel the levator tears. You can measure the overdistension of the muscle. You can even, to a degree, feel whether a sphincter has been reconstructed properly. With a rectal exam, it's just that with a sphincter, the minor forms of trauma you cannot really pick up with your fingers.
Yeah.
You can do that for the levator. You can pick minor trauma up with your finger. But for the sphincter, you really need the scan.
We need to do perineal ultrasound, and it gives us a definitive diagnosis. We don't need more improved imaging like MR or CT.
No. For the sphincter, MR is useless. In fact, Giulio Santoro just said as much. It's useless for the sphincter. And so nobody does that.
Ultrasonography have really improved, especially in the last few years, perineal ultrasound especially.
But there are purely physical reasons for that. Because with an MR machine, the moving parts are very heavy.
Yes.
So they have to be spun up and they have to spin down. And this is why the temporal resolution of the images that you get is really low. And the other problem is that with MR, you obtain slices.
Yes.
There are now machines and there's software that extrapolates from those slices so that you get a block of imaging data, and then you can vary the direction of your slices. That's true, but it's very recent. And with 4D ultrasound, the moving parts are much, much smaller and much lighter, so that we can get, with the fan of a 4D machine, we can get a full volume of data 4 times a second. And in that volume, we can place our slices in any arbitrary fashion, which means that we can follow a structure or we can follow a maneuver. So you can't really assess prolapse properly with an MR because, and you cannot assess ballooning of the hiatus very well with MR. We've tried, it's very difficult because you have to have the right plane. And okay, the patient does a push. You shoot your MR. You realize I'm in the wrong place. So you adjust your slice location and you get the patient to push again and you shoot it again. And you may have to do that 20 times until you get it right. With ultrasound, you do it once because you have a volume. You don't have slices, you have a volume. And then you pick the right location for the slice you want in the volume. You don't have to do it again and again. It's already there. You just need to find it.
Thank you very much for this advice. I'm going to keep them in mind. My last question, how did you find our second PET-KOZ Congress?
It was very interesting because there were a lot of aspects that do not normally feature in a urogynecology or in an imaging meeting. So very different. And some of that content was very interesting. Some of that content was a little strange. But that is, of course, that is understood in cosmetic gynecology.
Yes.
A lot of people try out lots of things,
Yes.
and some of them are interesting and some of them are just a little weird. It's the way it is.
People are trying.
But to bring, because there is a link, there is an overlap. And with pelvic floor imaging, that is obvious because hiatal ballooning is strongly associated with vaginal laxity. And that is one of the core concerns also for cosmetic gynecologists who deal with sexual dysfunction. So if we want to tackle sexual dysfunction that is associated with an overstretched or damaged pelvic floor muscle, then we need to treat that pelvic floor muscle. Yes. And for the time being, there are many questions to answer and there's much work to do before we can do that properly.
I hope you liked it and we are waiting for you next year in our third Congress. Yep. Thank you very much for your time.
You're very welcome.